All right, good morning, everyone, and welcome to the Immune Deficiency Foundation's SCID Compass Lunch and Learn. Today, we are exploring B-cell reconstitution and IgG infusion. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this program. We are excited to host this event for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your PI journey. Today's program is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Before we get started, I would like to point out a few housekeeping items to keep in mind for today's program. This afternoon, we're using the Zoom webinar feature, which means that attendees should be able to see the slides and our panelists and be able to hear myself and our panelists speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions at the end of the presentation, and you are welcome to submit any questions you have as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer, please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. Today's program is offered in partnership with the SCID Long-Term Follow-Up Project. Many of you tuning in today are doing so because you are an individual, parent, caregiver, or friend to someone living with severe combined immunodeficiency, or SCID. SCID Compass, an educational program of the Immune Deficiency Foundation, was created in 2018 with the purpose of guiding parents, families, and the medical community through the journey of learning about this rare, life-threatening medical disorder and find support to navigate the health challenges along the way. All of our SCID Compass resources can be found by visiting www.scidcompass.org. The website offers a robust variety of both online and principal resources for anyone eager to learn more about this condition or share information with others. Topics cover every step in a family SCID journey, from newborn screening to return home after treatment and everything in between. You can view the website in English, Spanish, French, German, Portuguese, or Tagalog by clicking on Select a Language in the upper navigation. We also offer monthly lunch and learns, such as the one you're at right now, and support all of the great programming IDF offers to the PI community. And now I am so pleased to introduce our presenters for today. Manish Butte is the E. Richard Stein Endowed Chair and Professor of Pediatrics and the Division Chief of Immunology, Allergy, and Rheumatology at UCLA. Victoria Dimitriades is the Division Chief of Pediatric Allergy, Immunology, and Rheumatology, and a clinical professor with the Department of Pediatrics at UC Davis Children's Hospital. Welcome to you both.
Victoria and I are going to talk today about, as Emma mentioned, B-cell reconstitution and IgG replacement. And that's sort of a mouthful of a title, but we have come to learn from a lot of our work now with parents of SCID children that there's a lot of questions about how the immune system recovers after a bone marrow transplant. And in particular, what are those factors that help the bone marrow recover in a way that children can outgrow the need for immune globulin replacement? On the flip side, some bone marrow transplants result in a situation where the B cells, the antibody-making cells, don't recover fully. And some of these children with SCID then require immune globulin replacement for many years. And so there are a lot of puzzles and questions around this path that children's immune systems take after bone marrow transplant. Will they head into a realm where their B cells start to recover and they can make their own antibodies, or not? And do they need replacement antibodies through the immunoglobulin replacement therapies? So we're gonna, Victoria and I are gonna try to dive into this topic to explain a little more about what I mean when I talk about B cells and antibodies and the recovery after a transplant. And then Victoria is going to take the second half of the talk and explain about immunoglobulin replacement therapies, immunoglobulin that's given intravenously and subcutaneously, and et cetera. And so, we're eager to take your questions. We're not planning on filling a whole hour with our slides. There really is going to be plenty of opportunity for you all to ask questions and participate, get your questions out there. Just to reiterate what Emma mentioned, we can't give specific medical advice to any of you about your children, but we certainly can try to paint a picture with broad enough strokes that you'll be able to understand the general patterns that we see in children with SCID as they recover from transplants, and hopefully you'll be able to learn something about what's happening in your own household. Okay, so with no further ado, I'm going to request control from Victoria's screen and then get started. Okay, so the first slide highlights David Vetter, who is the bubble boy child, and from decades ago, how we used to manage SCID required children living for many months and years in isolation before they could tolerate a bone marrow transplant. The first successful transplants were done in the very late 60s and early 70s, and those transplants have led to a revolution in our ability to save children with SCID and get them to not have to live in a bubble, but can live a normal life. In fact, because of newborn screening and because of our tremendous ability to get bone marrow transplants done early within the first 3 or 4 months of life, what we see is more like what you see on the right, which is newborns, very young newborns being identified in the first few days of life. In California, we're identifying these babies with SCID typically by the time they're 1 week old. In some states, it's even earlier. These babies are brought to the hospital and they're protected or given all the treatments they need, and in preparation for a transplant, as you can see in this baby here, by the time the baby's around 2 months old in this case. This is one of our I think one of our cases. This transplant was able to be done even before the baby was able to sit up. And so this is the world that we live in now, is that many babies get their definitive treatments and cures long before they're able to remember an IV or an injection. And so fast forward months and years, sometimes these babies still require immunoglobulin treatments because their B cells aren't working well. And that really is what we're trying to talk about today, is to understand, even though we're curing them of their immune, the T cell deficiency part of their immune deficiency, right, or from their early age, some parts may not be cured. Okay, so just to highlight what SCID is and how we think about immune reconstitution, it's important to know how the normal immune system develops. And so I stole this figure from a UK immunodeficiency website, sort of the parallel to the IDF in England, but they had this very nice picture that shows how blood cells are first formed in the bone marrow in the form of what are called stem cells, or hematopoietic stem cells. That the word hematopoietic means that these are the stem cells that form, that give birth to the whole heme system. And the blood system includes red blood cells. You can see erythrocytes down lower, platelets, eosinophils, basophils, all on the left. And on the right, you see another branch of development of these stem cells called lymphoid progenitor cells. And those are the cells that give rise to T cells and B cells. And these cells are white blood cells. They're a lot like the other white blood cells. They have a different role in the large dance of how white blood cells all organize to fight infections. And they play a special role. In fact, such a special role that when children are born unable to make T cells, they face this very serious disorder that we call SCID. And so SCID is where T cells are not formed. That is what we mean when we say SCID. Genetically, oftentimes there's a gene that is needed for the hematopoietic stem cells to go through these stages and become a T cell. And if that gene is broken in some way, then those T cells don't get formed. That's SCID. We also know that many genetic lesions that lead to SCID also affect the ability to make B cells. And so there are some SCIDs where T cells are missing, and there are some SCIDs where T cells and B cells are missing. But we always see the T cells missing. That is part of the definition of SCID. And even in the cases where the T cells are missing and the B cells are still present, most of the time those B cells don't work very well. And that's because T cells and B cells have to work together in order to make antibodies and to fight infections properly. So again, in the situations of SCID, where only the T cells are missing, the B cells still just aren't able to do their job very well. And so that's why we call this a severe combined immune deficiency, is because the T cell arm of the immune response and the B cell arm of the immune response are both broken when the T cells are missing. Okay, so this is a severe immune problem. And whenever there are severe immune problems, we really have to reach for drastic solutions to try to reset the immune system. And so how do we reset the immune system? Through something called a bone marrow transplant. These are also called hematopoietic stem cell transplants. And for the sake of trying to keep this discussion general for most of the parents who are taking care of children with SCID, I'm not going to talk about gene therapy here, but gene therapy is a form of bone marrow transplant. And a lot of the concepts that we bring up here about how B cells form and et cetera, they also apply in gene therapy. So in bone marrow transplant, it's necessary to take the disease stem cells, get rid of them, and replace them with healthy stem cells. And those healthy stem cells can, if you remember the slide before, then they will form all the white blood cells and red blood cells and neutrophils and monocytes and T cells and B cells that weren't able to be formed properly from the bone marrow that had the SCID gene broken. So the bone marrow transplant itself is really like a blood transfusion. It actually looks like a blood transfusion. If I go back to this first slide, in fact, you can see the bone marrow transplant right here. This is a bag. It looks like blood. It looks like a blood transfusion that's going into the baby, but in fact, those cells are enriched for these stem cells. And those stem cells then can form a new immune system, these healthy stem cells. Okay, so the bone marrow transplant process itself will restore the ability to make T cells. And these are our expectations as the body receives that transplant of hematopoietic stem cells, HSCs, here in the middle. Victoria, can you guys see my cursor when I'm moving it around? Yeah, okay. Yeah, so these HSCs will go into the baby. And you can see here the baby born with SCID has no T cells, and so it has the definition of SCID. These HSCs will go into the baby and begin to form, grow into T cells and into B cells and all these other cells. Now, the old bone marrow itself that was in place may have been able to make other cells, other white blood cells like neutrophils and myeloid cells and even B cells. It's important with the bone marrow transplant to replace those, the immune system, in a way that all the blood cells come from the new stem cells. And so you can see here, even though B cells were able to be made in this baby, even though the baby had SCID and couldn't make T cells, but could make B cells. After the transplant, the goal would be to have B cells coming from the green stem cells, from the new stem cells that were put in during the transplant. That's important because then these healthy new B cells can work with these healthy new T cells and work together. And as I mentioned, T cells and B cells have to be able to work together in order to be able to produce a good immune response, to make antibodies, to fight infections, et cetera. And so this is part of the expectation that we like to see as babies undergo transplant. Can we get them to grow new T cells? Of course, that's key. That is SCID. We need to get rid of SCID, and we need to be able to make the baby grow new T cells. But we also want to be able to grow all the other blood cell types from the new hematopoietic stem cells so they can all work together well. And what is the timeline of those cells coming online, appearing, those green cells appearing? They don't all come on at once. And this is part of the reason that babies need to be hospitalized for many days and weeks, and even in some cases, months after transplant, as we wait for these blood cells to come online and start growing from that new hematopoietic bone marrow. So if the stem cell infusion occurs here on day 0, fresh bone marrow stem cells making their way into the blood, they actually find their way into the tissues of the bone. They don't have to be injected into the bone. They can make just from the veins, they find their way into the bone, and then they sit there, they plant there, and then they begin to form new cells. That process of these stem cells forming new blood cells is called engraftment. The graft is those stem cells, and they engraft into the tissue of the bone, and they start to make new cells. And during the period between the infusion of the stem cells and the engraftment process beginning, there is a period of uh, quietude where the immune system isn't being formed yet. And this is a time when there is a very great risk of infections. There aren't any neutrophils floating around to be the foot soldiers to fight bacterial or viral infections. In fact, all the blood cells are low, called pancytopenia. And there's a lot of risk of infection and organ toxicity from the medicines that are given prior to transplant. But if everything goes well, as the timeline kicks in and the engraftment process kicks in, and blood cells start to form. Neutrophils start to form very early on, typically even within the first 2 weeks. Red blood cells, platelets, other cells start to turn on within the first month. And it usually takes about 100 days, 3 months or so, before the first T cells start to show up in earnest in the blood. B cells, the highlight of this talk, B cells take even longer. There are many B cells and many patients with B cells that don't really start making B cells even in small numbers until about 3 or 4 months. And in many of our patients, it can be 6 months or more before they're really starting to crank out an appreciable number of B cells. In fact, even though we have discharged many of these babies home from the hospital, they may be spending the next few months or years continuing to grow enough B cells in their blood that they can then fight infections and be able to handle vaccines and et cetera. During this whole period, there are a number of medicines that are being given along the way. Early before the transplant, many children undergo what's called conditioning. This is also called chemotherapy. And this conditioning can help the bone marrow to grow properly. I'm going to talk a little bit about that in the next few slides. During this whole process, there are other medicines given to prevent the immune system from attacking the host, to keep the body healthy while the new immune system grows and becomes tolerant of its new host. And so there are immune suppression medicines needed for months or years, typically after the transplant, slowly weaning down on those medicines to the point that the immune system can grow healthy and not be attacking the host. So I've mentioned now the word B cells twice, and I just want to make sure that we all know that these white blood cells, B cells, are responsible for making antibodies. When we think about immunoglobulin or antibodies in the blood, that's what B cells do. There aren't any other cells that make antibodies. B cells are the ones, the white blood cells, that make antibodies. And typically they make antibodies on their surface, and then they float around the blood looking for infections. When they sense an infection, they can secrete those antibodies. As you can see here, they fire them off. And in fact, the levels of antibodies can go up in the blood during infections because these B cells are cranking out antibodies and saying, go, fight those infections for us. And so this is the normal process of B cells. What they do for a living is make these antibodies. If they've been exposed to an antigen, to an infection a couple times, maybe it's a vaccine, maybe it's an infection a couple times, 2 or 3 times, these B cells actually start to mature into a form of cell called plasma cells. And plasma cells are permanently making and secreting antibodies. They don't wait for infections to do their thing. They're just always making antibodies, trying to protect you from an infection. And this is one of the things that we like to take advantage of in vaccines. If we can give a vaccine and then a second dose and a third dose, like many of you got for your COVID vaccines, Then what you start to do is make plasma cells, and those plasma cells just make antibodies day and night, making antibodies and filling up your blood tank with a little bit of antibodies against all the different things that you've been exposed to or that you've been vaccinated against repeatedly. If you've had 2 or 3 doses of COVID vaccine, now your plasma cells day and night are going to make a little bit of COVID antibodies. As long as those plasma cells stay alive, they're going to keep making antibodies. Now, plasma cells, like all the cells in our body, don't live forever. They live for 3 or 4 or 5 years, maybe as long as 10 in some cases. And so these plasma cells have to either regrow themselves, make copies of themselves to keep the process going, or over time, your ability to make an antibody to a particular antigen will fade away. And we know that that latter is true. That's why we give boosters throughout life. That's so many of you who have turned 50 know that you have to get a shingles booster, even though you had a chickenpox vaccine when you were younger, and tetanus boosters every 10 years, et cetera, et cetera. We know that we have to give these vaccines over and over again at some interval to keep a crop of plasma cells alive so that they can keep making protective levels of antibodies. And if we don't do that, slowly then over time, our bodies get rid of these plasma cells, make room for new plasma cells, and make new antibodies. And those older antibodies that might have been protected to, that protection will fade away. Okay, so what are these antibodies? Oh, sorry, what are the plasma cells and their development after transplant? Now I'm zooming in. The last figure you saw showed B cells coming alive after about 100 days. Now I'm going to dive into the different types of B cells in this figure. And one thing we see after transplant and around 100 days is the B cells kicking in. I think you saw that in the last figure. It's very interesting, but what's commonly seen is an overshoot of B cells for the first year. The bone marrow produces a ton of B cells in that first year. Plus, some B cells sometimes make their way into the hematopoietic stem cell transplant graft itself. So as they intravenously inject those stem cells, some B cells are coming along for the ride, and they make their home inside the body, and they will increase the total numbers of B cells. So oftentimes you'll see an overshoot. Then over the next few years, that those B cell numbers come back to a set point, and the set point can be at an appropriate level that the body acts as if it has a brand new immune system and doesn't have SCID anymore. It takes time for those B cells to go through various maturational processes, and that's one of the reasons why we know that B cells themselves aren't fully functional, even though you can find them in the blood for the first year after transplant, or even 2 years after transplant. There are many, many papers and our experience that shows that you can give vaccines to babies after the SCID transplants, and they won't take the vaccines for the first year to 2 years at all. The real reason for that is because of memory B cells. So memory B cells are those B cells that remember, and like plasma cells, remember previous infections and are able to make long-lasting antibodies to protect you from them. And you can see here, memory cells and plasma cells are down here at the bottom in blue and purple. They really are at almost absent levels for the first year. It's only at a year that you start to see some of these numbers, and it really can take, in many patients' cases, 2 years before you start making enough plasma cells and memory B cells that the vaccines will actually take. Then when you get a vaccine and a booster, those memory cells are like, okay, now I know what I'm doing. I'm going to make some antibodies for the next 10 years as a result. This is one of the reasons why after transplant, many babies require immunoglobulin for months or years because their B cells just don't know what they're doing for the first few years. Now, the key is, can they outgrow the need for immunoglobulin? Can you make enough B cells after the transplant? And can those B cells be functional enough that the need to have other people's immunoglobulin being provided can fade away? And that is really still an open question that we're trying to solve in the treatment of babies with SCID. I'm going to show a paper here that now is almost 10 years old, but still represents one of our major summarizations of knowledge that we had up to 2013. And then I'm going to tell you a little bit about what we've learned since 2013 about this particular question. How can we get B cells to grow well, to reconstitute well after a SCID bone marrow transplant? What Elie published in his paper was that in his experience, and I think this echoes all of ours, the major reason that controls whether B cells are functional after transplant is the underlying genetic cause of SCID. There are some genetic causes of SCID that really break B cells badly. And thus it requires a whole fresh new immune system, including good numbers of B cells to grow anew before you'll ever have a chance of making good B cell function, antibody production, vaccine responses, et cetera. So the genetic cause of SCID was really thought to be the most important factor that controls the success of B cells after transplant. The second most important factor has to do with conditioning. So remember, conditioning was that chemotherapy that babies receive for a few days prior to transplant. Not all medical centers do conditioning. Duke, for example, has done over 400 children with SCID without doing conditioning chemotherapy prior to the transplant. Many centers do. And so it has been studied, and Ellie's paper suggested this, that conditioning regimens very much are important for supporting the development of B cells. We know from the Duke experience that there are children who are able to survive transplant and make B cells that are functional. But the chances of that are much lower than in other centers where conditioning regimens are given, chemotherapy is given. And here are the numbers to show that there is a good success of getting functional B cells when conditioning chemotherapy is given, and a lower chance of getting functioning B cells when conditioning chemotherapy is not given. Now, can you have functional B cells without conditioning? Yes, as I mentioned, the experience from Rebecca Buckley's group now for decades has supported that there is some rationale to it. Oops, wait, sorry, I didn't mean to go forward. Okay, and then one last point is what form of chemotherapy is best able to get B cells to grow after transplant. We've really focused in a field on this one chemotherapy agent called busulfan. There's an equivalent or a similar agent called treosulfan that's used in some studies. Busulfan is a very powerful chemotherapy, and it seems to be one of the most important for getting rid of the bone marrow in a way that allows new bone marrow to grow and especially new B cells to grow. The dose of busulfan needed, and if busulfan is needed at all in order to make B cells grow, is a very important question. And because of Ellie's paper in 2013, the Primary Immunodeficiency Treatment Consortium, the PIDTC, gathered together in the subsequent years and decided to launch a clinical trial to test this question. And that's why I say the jury's still out, because there is now ongoing today a trial, oops, I did it again, that allows our field all over the world to learn by giving children with SCID different doses of busulfan or not, and tracking their B cell development afterwards based on their genetics, based on other factors, to try to understand what's the best dose of busulfan, a low dose, a medium dose, et cetera, to try to get the B cells to grow and yet producing the least amount of harm. Busulfan is one of those chemotherapies that does produce harm in children if it's not well tolerated. And so adjusting those doses and getting all that fine-tuned can be done. But what are we fine-tuning towards? What is the best dose of busulfan? That question is still being addressed. We do think 5 years from now, 10 years from now, when these studies are done, when there are enough babies in the world who have enrolled in this trial and data are gathered together, we will be able to say for sure that I'll be willing to put down a bet that busulfan is going to be shown to be successful in getting B cells to grow after transplant. I think we're all, as a field, going to be able to say that busulfan is needed. And importantly, we'll be able to give advice to all the transplanters around the world as to what dose of busulfan to shoot for so that you can get the best B cells and the least amount of harm. Okay, so one transition now I'm going to do and hand off to Victoria to talk about immunoglobulin and replacement therapy. Immunoglobulins come in many different flavors, and these are being all made by B cells. B cells start by making IgM, this sort of wicked-looking molecule here that has many different parts to it. So if you actually look carefully, you can see here that there are 5 antibodies, 1, 2, 3, 4, 5 antibodies, all joined together by this little red brick called the J chain. And that's what an IgM antibody is. It is a circulating antibody that's in all of our blood. IgG is another major antibody. You can see here it's one antibody. It has 2 arms on it, this arm and this arm, and both arms here can bind to antigens, not to different antigens, the same antigen. IgD is very similar, IgE and IgA. IgA, you can see, actually has 2 antibodies strapped together. Here's one on this side, if you look closely, and here's another. And they're also joined together by this J chain and by this orange strap called the secretory component. So these different antibodies serve different roles in our body. IgG is the most important one. It makes up about 80% of the immunoglobulins in our blood. And it's the most important for protecting long-term us from infections of the blood. All these bacterial meningitises and sepsises, this is what IgG is protecting us from. IgM also plays the same role, but it's an earlier responder. As an infection sets in and B cells are starting to boot up their ability to fight antibodies, fight infections with antibodies, they start making IgMs early on. And it's because they have those 5 different heads on the antibodies that really allows IgMs to work so well, even though it's early on in the immune response and they haven't made such great quality antibodies yet. IgMs make up about 10% of the immunoglobulin in our blood, and these are just earlier phase responses. These other antibodies are more specialized. IgA is that 2-headed one that I talked about. That's found in our body's secretions. It's found in the blood to an extent, but a minor extent. What's more importantly, only about 10%. What's more important is the IgA that's secreted in our tears, in our respiratory tract, in our throats, in our lungs, in our gut. That IgA is critical for controlling bacterial and viral infections at these surfaces of our body where we're making contact with the outside world and where infections are most likely to get in. So they protect our external openings. And then IgE, the last thing I'm going to talk about, is typically at such a low level in our blood, 1/1000th the level of IgG, that it plays a minor role. And evolutionarily, we think IgEs were formed in order to protect us from certain venoms and certain toxins. Over time, we have come to also learn that IgE is responsible for allergy responses. And so these IgEs actually bind to cells called basophils and mast cells, and they can tell those mast cells to release histamine and other contents, which protect us from parasites and protect us from venoms. And so IgE plays a role in allergy responses nowadays. IgD is just found on surfaces of immature and early B cells. It doesn't play an important role in fighting infections. So these are the 5 different isotypes of antibodies, and they play different roles in our bodies. And we need them all in order to really have a totally healthy immune response. But we can take care of patients who have low levels of some of these antibodies and sometimes make up for it. Okay, and now I'm going to hand off to Victoria.
Thank you. I appreciate it. That was a wonderful talk. Thank you so much. I think you can just finish the rest of my slides since you're kind of on a roll right now. I'd love that.
I'm gonna enjoy my coffee and listen to you.
So yes, this was such a great lead-in. One of the things we know is that we have certain ways to protect certain parts of our immune system, and we can't blanket protect them all in one way, but we try and use many different means to go at this problem. And so the one thing we'll talk about today, at least for this section, is the IgG replacement. So the products that we're going to review today are really only meant to replace the IgG component of the immune system. We cannot replace IgA or IgM. But overall, the IgG antibodies are protecting you from recurrent infections, specifically mostly bacterial infections, the most common of which are ears, sinus infections, and lung infections. But as Dr. Butte mentioned, there are other more serious infections like bloodstream infections and neurologic infections that you can be protected from too. Overall, when we talk about IgG replacement, we're really focusing on those bacterial antibodies, but we do know that there are some antibodies to viruses and probably fungal infections that are included in this, although it's just generally not the main impact of our replacement. I find this really interesting. I need to remind patients a lot, IgG is actually a blood product, even though it's totally clear when you see it, it started as an actual blood product. And we know that this is a really great product because it's a pooled product using up to about 1,000 different donors. So you can imagine the really wide range of antibodies that we can see in that pool. IgG itself is actually quite safe. And the reason for this is because there's a lot of testing that happens and filtration that happens to this product. So in order to become a donor for immunoglobulin, you actually have to go through a screening process where they check for all manners of infectious diseases. And once you donate that first dosing, it's actually held on to until you return again in 3 to 6 months for a second donation. And that second donation is actually screened again. So this is an incredibly, safety check way to make sure that whatever is released into the pool of product that is utilized by our patients is really, really protected. The ultrafiltration process that occurs is a little bit different depending on the company. So you'll hear about many different companies, none of which we're going to discuss today. We're just talking about this as a general product. Each of them has kind of their own proprietary way to filter the products, but generally they're very similar. And sometimes we will recommend one product over another based on some of the specifications of the product or based on your underlying immune condition. For instance, if you have a kidney issue or if you have a high clotting issue, we may recommend a specific product or a specific way that we recommend you receive the IgG itself. Dosing, I put this in here because I want people to kind of understand that this is an art and not a science when it comes to dosing. We aim for a general amount, usually around 500 milligrams of IgG for every kilogram of weight. But after that initial dosing, we definitely look at the patient's daily experience, infection risks, things like that, to adjust the dosing to make sure we're giving them the optimal amount that they need. Every patient is a little bit different. So if patients are having issues with infections, most commonly we talk about ear, sinus, lung infections, like I mentioned, but of course, if there's any more significant infections, we'll adjust based on that. Also talking about the time ranges of when you're getting your dosing. If towards the end of your dose, let's say you have 1 week left before your next dosing, are you starting to have other issues? Are you getting nasal symptoms, sniffliness, fatigue? Those are things that we talk about when we review our dosing and adjusting how we give it. So intravenous immunoglobulin, we're going to call it IVIG, and it is in the name, it's in the vein therapy. So this is one modality and probably the most common modality just because it's been around the longest. What's important to talk about with this is each modality that I'm going to discuss, or both modalities that I'm going to discuss, each have their own pros and cons, and everyone can decide sort of what they want to do based on their lifestyle and based on what they prefer in terms of their medical care. The in the vein therapy, the IVIG, needs an IV placement every month. So it is noticeably, something that has to be thought about. In some cases, post transplant, you're going to already have an indwelling catheter, and in that case, you can continue to use that until that doesn't need to be there anymore. Occasionally, pre-medication is given. It depends on the patient. It depends on the team, though it's not always necessary. And then topical anesthesia can be used prior to IV placements, which is kind of nice for our kids. There's many different ways we can numb the area before we need to put in IVs in order to make it a better experience. Hydration before you go in for your infusions is important to reduce side effects. So make sure in the days before that you're getting your IVIG, that you're maintaining good hydration. And then when we give this product, we give it every 3 to 4 weeks, again, adjusting based on the patient depending on needs. And it can take 3 or 4 hours for infusion appointments. By the time you get there and check in and sit, it's important to remember to bring distractions. This is when I tell my parents, this is a judgment-free media time. You do whatever you need to do to get them to stay there and have fun and not feel like you're trying to hold them down while they're getting infusions. This is a little bit complicated in terms of this graph, but what I really wanted to show you here is this is where you get your IVIG dosing. So day 0 and let's say day 28, so that would be 4 weeks. And on this left-hand side is the serum IgG concentration. So what's important to note here is that at some point you hit a low level. As soon as you get your IVIG, your IgG level in your blood goes up, and then it slowly comes back down. The IgG will eventually come down, and if you let it go, it'll go into the low range again. And then when you get your next IVIG dose, you get a nice big bump, and then you come back down again. During this time is where we start to worry that somebody might not be protected enough. That's that last week before they get their next dose. So it's something we ask questions about when patients come in to see us. Subcutaneous immunoglobulin, so we're talking about the same product, maybe in a different concentration, is given under the skin. And instead of getting that one big dose once a month, you can actually give this once or twice a week or once every other week as well. This is kind of nice for families as we transition them because it can be done at home actually, and we can train our caregivers to do this at home once a week. The needle placement can be done by whoever's administering it. And as you can see here, the needle is not like the IV needles that go into a vein. It actually goes into your skin. So it's more of a right angle sort of that you just push through the skin and it lands in the appropriate area in the subcutaneous tissue. And in that space, you give a smaller amount of the IgG product. Once weekly is usually pretty typical, and it can actually sit in there in that space and then get absorbed slowly over a few hours. That dosing that goes into the skin will eventually make its way back into the bloodstream and be utilized in the same way that you do the IVIG. Just with IVIG, sometimes pre-medication is given. It's not always necessary. You can also do topical anesthesia cream over the area before you push that through, and our kids, prefer that, of course. Like I mentioned, it can be given every 1 to 2 weeks. Sometimes we can give it every day if we need to, if people are having issues. Sometimes we can give it twice a week. We're very flexible in terms of how it's given. The infusions, depending on how much you're getting and what the product is, can last anywhere from 30 minutes to 2 hours. Patients like this because it can kind of work into their lifestyle. They decide a day every week that they want to do this and set aside time for it. But it is really important that you need to be able to rely on yourself to do this. So you have to be able to schedule yourself pretty consistently to get this treatment. Although we do have a little bit of leeway. You can also adjust where you administer this subcutaneous immunoglobulin. I didn't put a picture on here, but it can be given in the thighs, in the abdomen area, in the upper arm areas. There are many different places where this can be infused depending on your comfort and preference. And we can give it depending on how much you're getting in different numbers of sites as well. So here's that kind of graph again that I was showing you before. This big spike is what we see when we do IVIG. So you get that large spike of IgG level. But when you give subcutaneous IgG, you have more of fewer ups and downs. It's more kind of in this nice sort of medium consistency of IgG level. And we tend to like that because although the highs are nice when you get IVIG, the lows can put you kind of in a more precarious place in terms of your infection risk. So sometimes we prefer using subcutaneous IgG in order to keep a more moderate level, basically. Follow-up. So I put this in here. This is probably more related to long-term follow-up if you're going to continue to be receiving IgG, because early follow-up when you're first on IgG after transplant is a little bit different. You're clearly getting labs more frequently. Overall, once you hit kind of a steady state, if you're continuing on IgG, we'll do blood counts and chemistry and an IgG level anywhere from 6 to 12 months just to track over time. We're going to review any infections at that time, and we're going to adjust dosing as needed. Of course, if you're having issues earlier than that 6 to 12 month follow-up time, we ask our patients to give us a call ahead of time to see if we need to adjust anything earlier. We're going to review side effects, which I'll talk about in a second. You can have things like headache or fatigue or local reactivity, especially when you're getting the subcutaneous infusions. And there's things that we can adjust in order to fix that. What's important to remember when you're on IgG therapy is that this is pooled antibodies. And so it's going to include a lot of other antibodies in addition to what we're focusing on to keep you protected. And therefore, if you're going to a medical center and you need evaluations, it's something you should remind them of, that you're on IgG replacement, because it is hard to identify other types of infections when you're on already IgG antibody therapy. So a lot of the times when we test for infections, we're looking for antibodies, right? We're looking for the antibody to, CMV. Let's say. Once you're on IgG replacement, you can no longer trust that IgG is not from the replacement antibody. So it's important that the team uses other modalities in order to identify infections. It's also important to note that you can have other antibodies that can come through the IgG replacement therapy that are not active antibodies, they're just present. And it includes things like thyroid antibodies and anti-nuclear antibodies. They eventually degrade during the product, usage basically, but if you're doing testing for thyroid antibodies or anti-nuclear antibodies, that might come up with a false positive test, because those are very common antibodies in the population. Side effects, fairly similar side effects for IVIG and subcutaneous IG, mostly and more commonly is headache, which occurs anywhere from 8 to 15%, but our patients can also report after their infusions, they might get fatigue. A lot of them will sleep more on the day that they get infusions. They can get aches or fever and chills, sometimes nausea, diarrhea. These can be related to rate and frequency. And so there are things that we can do to adjust these and decrease the side effects. Subcutaneous has pretty much the same side effects, but at a lower frequency. So sometimes we will recommend changing product administration in order to decrease those side effects. With subcutaneous IgG, you can also have a lot more local events that occur, mostly discomfort, a little bit of swelling in that area. But as I mentioned, we can modify the actual needle placement, location adjustments, and help make those better. Vaccines. So Dr. Butte mentioned this before too. I put this first, check with your teams first. They will direct you in terms of how and when you will do vaccines post-transplant. But at some point, once you are cleared to restart the non-live vaccines, and you've done all that, if you are remaining on IgG replacement, we still recommend the yearly influenza vaccine. And the reason for that is that IgG replacement collection occurs usually in the year before the current vaccine season, the current influenza season. So it doesn't actually usually contain any antibodies for the current influenza season. So it is important to get that in addition to that. Live vaccines are going to be very much directed by your care team. Live vaccines are things like measles, mumps, rubella, varicella. In some older individuals, some of the shingles vaccines are live as well. So it's important to discuss this with your team, because that is a different stress on your immune system that needs to be taken, utilizing function from a different pathway. Caregivers, however, should be vaccinated. So we recommend that all of our caregivers are vaccinated. It is important to note that when getting vaccinated, the non-live vaccines are fine, but any live vaccines that are obtained by caregivers need to be cleared first with your team, because you could actually pose a risk to your child if they're post-transplant during that time. So to sum up, supplementation is important until the B cells can return to making antibodies again. We acknowledge that this may or may not happen, but we always hope that the B cells will be able to start producing. There is flexibility in terms of your IgG replacement, which can keep you safe and still be compatible with your daily activities. I've given you several options here that you can look into. And then finally, the eventual goal is to stop needing IgG infusions once the immune system is replenished. But obviously, we're still learning about this a lot. And as long as we keep you protected on the B cell side with IgG, and possibly even on the T cell side with other medications, including anti-infection prophylaxis, we hope to keep you healthy and have a long-term good lifestyle. So, and with that, I think I just thought this was kind of neat. Everybody loves the new Marvel, old Marvel stuff. So the bulk, IgG man, Captain Immunoglobulin, VDJ Widow, and Black Antigen. So
I like it.
Well, thank you so much, Dr. Butte and Dr. Dimitriades, for putting together that awesome presentation and sharing your expertise with the SCID and IDF communities. And now we're getting ready for everyone's favorite part, and we're going to dive into Q&A. All right. So our first question, and feel free to tag team, or if the question pertains to one person's section more than the other, you'll know what to do. All right, so for those patients who received reduced intensity transplant protocols and now have mixed chimerisms for B cells, is it more to have other immune/autoimmune related issues?
I think she probably meant, is it more likely to have
More, okay, yeah.
more likely to have other autoimmune related issues? So in general, mixed chimerism can be both a blessing and a curse. The blessing side of it is that there may be some exposure to antigens through the early development process of the T cells that allows those T cells to be more tolerant of the host and allows there to be less graft versus host disease. At the same time, there are now more and more evidence that mixed chimerism can result in two populations of cells. So chimerism means the population of cells that grows from the graft, and what population that comes from the graft makes up all the white blood cells in the blood. You would think that after a transplant, if I draw blood and I measure the population of B cells or neutrophils or monocytes in that blood, all of them would have come from that bone marrow transplant graft. But the reality is that many children continue to make some of their blood cells from their original SCID bone marrow, and at the same time make blood cells from their new engrafted bone marrow. And that process is called mixed chimerism. Okay, and so the mixed chimerism, if the match is very good between the new graft and the original immune system, then the chances of mixed chimerism resulting in autoimmunity is low. And this is where that blessing curse comes in. If the match isn't very good, then there's evidence that it can lead to more autoimmunity or less tolerance. So I think this is one of the reasons why we think about doing related donors and match donors, and you've probably gone through this with your children as the preparations are being made to figure out who's going to be the donor. This is one of those considerations that's going in, is to understand if there's mixed chimerism afterwards, will there be some degree of tolerance as a benefit if the matches are very good, or lack of tolerance.
Thank you, Dr. Butte. All right, next question. So this question is pertaining to the following up slide and discussion. And this individual asked, will you please address other testing modalities, for example, culture/test for organism only versus antibodies?
Yes, so this is a great question. I didn't go very far into it, but in general, what I ask my patients to do is to request PCR testing. You know, that's a nice word that we've heard a lot about in the last couple of years, but it is really looking for the actual organism itself rather than looking for antibodies that your body made to the organism. So PCR testing and, as you mentioned, culture are probably the two best ways. What I will say is sometimes those tests take a little bit longer. So if there is a concern for a specific organism, I would send those things and then probably start treating if there is a real concern for something, rather than waiting for those to come back before you start treatment.
Thank you, Dr. Dimitriades. All right, next question. In your experience, are immunologists generally open and available to consult with a child's pediatrician when it comes to vaccine introduction?
Yes.
Yes, they are in general. I think you really want to make sure that you find a pediatrician who aligns with your interests in terms of taking care of a child with a chronic disease. SCID, although it is cured by the bone marrow transplant, results in a state, as I mentioned, for months or years where the immune system is still regrowing. And it puts kids in a precarious state, oftentimes needing medicines to suppress the immune system or to protect from infection during that time. You want to find a pediatrician who has some experience in these things. I think that's going to be a very important part of making a good therapeutic relationship. If you do have a pediatrician who's experienced in these things, who has gone through it, for example, through their residency training, or afterwards in other cases that they manage, then they will have a better understanding as to why kids can't get live vaccines yet because they're still on immunoglobulin, et cetera. In many of our states, those kids who are on immunoglobulin, who are post-transplant, who haven't made good B cells yet, need vaccine exemptions because the schools may require an MMR vaccine, but they can't get it yet, et cetera, et cetera. You want pediatricians who are able to understand that and write those letters that are needed to get your kids into school and get them moving forward with their educational plan as their immune system is still forming.
I'll also mention that a lot of the transplant centers themselves have a form that they will send to the pediatricians or the local immunologists, if there's someone there, where they will give you very specific timelines for when they're ready to get the vaccines and which vaccines to give at what time. So if you request your transplant center, they should be able to send your pediatrician those items to make them more comfortable as well.
Wonderful, thank you both. Next question. Are there applications of B-cell reconstitution in testing or that are foreseen possibilities outside of BMT, for example, in cancer chemotherapy treatment?
Definitely, yes. So there is a form of cancer, these are B-cell cancers called lymphomas or leukemias. And many of these B-cell cancers are treated with medicines that eliminate all the B cells. Then, if the cancer is cured and if the body, as the body recovers, those B cells have to grow back again into the blood. That process of the B cells forming in the bone marrow and coming out into the blood, being naive and immature initially, and over the course of months or years, forming enough memory cells to form long-lasting immunity, all the stuff that I talked about for SCID, reconstitution of bone marrow transplant, after bone marrow transplant, that's also true in those patients who have cancer chemotherapy and who undergo B cell depletion treatments like rituximab. Maybe you've heard of that one. That's the most popular B cell depleting therapy that's out there. So absolutely, yes, the lessons that we learn for rituximab treatment and the timeline it takes for B cells to grow and be functional applies very much to the condition of the bone marrow forming new B cells and waiting for them to be functional.
Thank you, Dr. Butte. All right, next question. Are these patients at a higher risk of viral infections? If so, can you share what viruses pose the greatest risk?
Yes. Go ahead, Manish. It's fine.
No, go ahead, Felix. This is where the IG comes in.
Yeah, so these patients are at higher risk for viral infections, but when we talk about viral infections, I think there's really two flavors we need to distinguish. There's viral infections like upper respiratory infections, like a cold that you catch, and then there's viral infections that we're much more significantly worried about, which are things like CMV, EBV, HSV. These are all different types of viruses that we worry about, and especially in the post-transplant period and pre-transplant period. So they are at risk for those types of infections. As far as the immunoglobulin replacement goes, we know that there are those types of antibodies in there. Like I said, it's not necessarily powered to protect you from those types of things, but we hope that partially it's helping in that way. The other thing that our teams will do post-transplant is monitor for these infections frequently in order to be able to treat very quickly if needed. There are not great prophylaxis therapies for these viruses, unfortunately. So we don't want to put somebody on a long-term antiviral therapy that we're not really sure is going to be very helpful to them. But if you track it quickly and frequently, you should be able to help these patients with infection.
Wonderful, thank you. And our last question for today, are children with XLA candidates for transplant? And is there an age limit for this procedure?
I happen to like this question, so I'm going to start, but maybe Victoria can jump in too.
No.
So first of all, the answer is yes. And yet, just to remind everyone, XLA in the United States and in most parts of the Western world is not treated with bone marrow transplant. It is not as fatal of a condition as SCID. We know that many children can live their entire lives. We manage 40, 50, 60-year-olds with XLA just by getting immunoglobulin replacement therapy regularly. They can live full lives. And for that reason, because it is not as demonstrably fatal as lacking T cells, bone marrow transplant hasn't been reached for as a primary therapy in XLA. Now, that being said, there are now groups, and I'll cite as a way of starting Neil Romberg's recent paper from Children's Hospital Philadelphia, where he looked at the economics of treating XLA patients for their whole lives with immunoglobulin replacement therapy versus a bone marrow transplant. Why? Because immunoglobulin replacement therapy is incredibly expensive year upon year upon year upon year, to the tune of tens and hundreds of thousands of dollars per year. If you think about those patients that we are managing with XLA in their 40s and 50s, they have had decades of immunoglobulin treatment at the tune of $100,000 a year. You're talking now millions and millions and millions of dollars. And bone marrow transplants aren't anywhere near that expensive. They're on the order of $500,000 to $1 million. These are all huge amounts of money. I know we're talking about, but when you're thinking about the health economics of treating XLA with immunoglobulin versus transplant, Neil Romberg's group did an analysis and found overwhelmingly that transplant is cheaper than immunoglobulin for the lifetime. That actually has relevance in countries where resources are limited and where you can't spend infinite amounts of money on immunoglobulin year upon year upon year for all the XLA patients. I am told that there are countries, in fact, where XLA is managed by transplant for this reason. It's just too expensive to give immunoglobulin year upon year upon year for these patients. The second reason that I think it's important to talk about bone marrow transplant for XLA is because a form of bone marrow transplant, which I alluded to earlier on in my talk, called gene therapy, is potentially a cure for XLA. So what is gene therapy? It is a form of bone marrow transplant where the bone marrow is taken not from some healthy sibling or parent or a matched unrelated donor, but instead the bone marrow is taken from the patient themselves, the XLA patient themselves. The gene, the BTK gene, for example, is fixed and then reinserted back into the patient. So their own bone marrow cells, now fixed of the BTK defect, are able to make B cells and grow a normal, healthy immune system. They will go through that reconstitution process that I just talked about, 6 months, 1 year, 2 years before they make some B cells. All of that will still be true, but now that the gene is fixed, they'll be able to make B cells, which their old immune system couldn't do. So gene therapy for XLA is potentially curative, and that is a form of bone marrow transplant. And in fact, there are now groups in the United States that are working, and around the world, that are working on gene therapy for XLA. I'm happy to say that UCLA is one of the places where this is being developed. One of our colleagues here, Don Cohn and Carolyn Kuo here, are working on a gene therapy for XLA, and I know other groups are too. And so, yes, I do think the idea that we can come up with a cure for XLA through a form of bone marrow transplant is one of the reasons why we do have to talk about bone marrow transplants and how XLA actually might be benefit from that path.
And then I'll just add in the second part of that question was, is there an age limit for transplant? And the truth is, overall, when we talk about age limits, it's mostly based on collecting things. So the older you get, the more likely you are to have secondary issues, infection issues, more chronic conditions. And so we definitely like to transplant earlier. However, with gene therapy, they are actually able to do this at a much older age, not much, but at an older age. So I think there's a lot of development happening there to where we are going to be able to use gene therapy for very specific conditions that have known gene alteration. So it's not for all transplants, but at least right now, very specific conditions where we could look at possibly utilizing this therapy in patients who have been on IgG therapy for many, many years and would like to explore it now, as an adult. So.
All right, well, thank you so much to each of you for addressing our audience's questions during Q&A. And thank you again, Dr. Butte and Dr. Dimitriades, for putting together this wonderful presentation. Thanks to our audience as well for your engagement and participation. So to our audience, if you have additional questions, you can always ask IDF. Go online and submit your questions to Ask IDF at www.primaryimmune.org/ask-IDF, or give us a call at the number on your screen. And that does it for this afternoon. Thank you so much, everyone, for joining us. Thank you, Dr. Butte and Dr. Dimitriades, for all of your efforts in this presentation. We really appreciate it. Thank you, our audience, for joining us, and we hope to see you at the next Lunch and Learn with IDF. Thank you so much. Have a great rest of your day.